You're listening to The Physician's Mind, raw stories and real talks from people striving for greatness in medicine and in life. This is where ambition meets action and where the relentless come to level up. I'm your host, Curtis Wilkerson. Thank you so much for listening. Let's get right into it. Today's guest is Elliot Justin, a veteran emergency physician turned healthcare entrepreneur and the founder of FirmTech, a company that's revolutionizing men's sexual health through smart technology. In this episode, we explore his journey from the emergency department to the startup world, his groundbreaking work on erectile fitness as a vital sign, and his vision for a future where data-driven care and sexual health are at the forefront of medicine. I hope you enjoy this episode. So, Dr. Justin, thank you for joining me today, sir. How are you?
It's a pleasure. It's great to be here. And I'm well, very well. My daughter's getting married this week, and I'm in a really good mood.
Congratulations. And would you mind sharing with the audience where you're joining us from, sir?
Yeah, I'm in Madagascar. My oldest grandson has a thing for lemurs, so we decided on the way to the wedding that we would stop at the Madagascar. We're at an Echo hotel right by the lemur preserve here. Kind of cool to watch them leap around in trees. It's fun.
And there you go, folks. That's dedication, joining the physician's mind all the way from Madagascar. So let's get right into it, Dr. Justin. How did your years in emergency medicine shape your understanding of people, performance under pressure, and the kind of doctor you wanted to become?
Well, I went to emergency medicine because I had this vision of just during the Cold War, and I had this vision of myself of sort of being, a spy, AK-47 in one hand and a black bag on the other. My father was Korean military and had won Distinguished Service Cross and Silver Star and Bronze Star in World War II, and I always had that desire. Emergency medicine was kind of a way of changing things, probably the closest way, at least back then, you get to experiencing combat in a medical setting. But I didn't really understand what I was getting into, and I don't think most physicians, frankly, do. But I had a great career. I think I probably took care of about 185,000 people. And the great thing about emergency medicine, as opposed to other specialties, is that you get to see, one, a wide range of people at their best and at their worst. You also you have to have a broad range of knowledge. So the narrower the specialty, the less interesting the contacts or valuable the contacts come with people in terms of learning about people. My oldest son, for example, is a retina surgeon, subspecializing in two things: retina trauma, pediatric retina. Well, he really doesn't get to have much contact with people. Doesn't have to develop differential diagnosis to a grade 3. He knows what the problem is, and his approach to them is really more about technique and applying the latest knowledge. So emergency medicine is kind of special in that area. You also in emergency medicine have to perform under pressure. There's time pressure, and there's also occasionally, not as much as people think from watching TV, but there's also intermittent life-saving situations or significant situations, people are really life and limb-saving situations, called that way, that you're involved in. So I think the way in which emergency medicine shaped me is it provided me with deeper knowledge of the human character, how people perform under pressure, not just the people themselves, but the doctors and the healthcare systems. And there's a lot of friction on the healthcare system side. There are a lot of breakdowns that occur. A lot of physicians under pressure simply retreat from work. They'll okay, I got the sickest patient. I'm not going to see anyone else in the department. Well, you can't carry on the way. So in emergency medicine, you have to the good emergency medicine doctors learn how to balance both knowledge, empathy, but also efficiency. And unfortunately, that's really the minority of physicians. And I learned that because I had a company called Pegasus Emergency Group. We eventually were in 11 or 12 states. We had 750 doctors and mid-levels working for the company. And as the company grew, the quality deteriorated because there weren't enough physicians that could deliver both high quality of care and also be efficient.
Very interesting. So you joined because maybe you didn't quite know what to expect, but you knew it was going to be potentially similar to the high-intensity environment that you were conceptualizing. You mentioned your son is a retinal surgeon, pediatric and trauma retinal surgeon, and he's got perhaps a little less variety than what you've experienced in emergency medicine, and that's part of the specialty that you enjoy. And understanding you have to perform under pressure, but also be knowledgeable, empathetic, and efficient. All very interesting points about emergency medicine. Now, was there any lessons that you learned in your clinical practice that have given you an edge as a healthcare entrepreneur? Because you're very involved in business.
Yeah, I am. Well, It quickly became clear to me in emergency medicine that actually it's not that complicated a specialty. There are basically 15 to 20 problems that occur again and again and again and again. And even in the era before people unfortunately went soft in the brain because electronic health records are telling them what to do and how to solve problems. Even before then, I started quickly thinking, hey, this is kind of like being a chef in a busy restaurant, and I've got 25 recipes, and I've got customers out there that I need to make them happy with. I'm crude analogy, but make them happy with high quality food, and also not the service is not going to be delayed. It's going to be efficient. That was interesting to me, and so the challenge again was, how do you in that type of situation, where are the mental challenges? Well, they're really not in the diagnosis, and even less so today because of electronic health record. The challenge is really in how do I deliver golden rule care and also move people along. And by golden rule, I mean the old golden rule: do unto others as you'd have them do unto you, versus the new golden rule, which is probably to some degree also the old golden rule as well too, which is the gold rules. And in medicine, not just emergency medicine, throughout medicine, people get the care they could be billed for, which is not necessarily the care they need. Then the biggest glaring example of that is advice. What do people most want from doctors? They want advice. One thing that really pisses me off is if I'm at a party and I hear someone ask a doctor for advice. The doctor says, "Well, I have to see you first." Bullshit. Does not care how you take care of your family and friends. And it has distressed me, the sort of disintegration of this Hippocratic loyalty, if you will, bond with a patient and with a community that's occurred over the course of my professional career. We owe it to people to give them advice. Unfortunately, managed care and Medicare pay zero for advice. Therefore, people don't get it. They get the two examples. You call me up and tell me to sprain your ankle, and I tell you, well, can you take 3 steps on it? Can you bear weight on it? Oh, you can do both those things? It's probably nothing. Put some ice on it. Give me a call back in 3 days. I get paid nothing. So the incentive is to bring you in, get an x-ray, put a splint on it, bring you back for a follow-up visit. And all that is terrible. That's not the way which we should be treating people. But you could give up $750, $800 of income just by doing that. And when I found, I found a company called SwiftMD, which is it's gone now, which is the second oldest telehealth company in the United States after Teladoc. Founded just around the same time. And I was inspired to found that company because I was the only doctor left in my group. This would be early 2000s, who would take patients from the calls from the field. And the nurses knew that I was the only person who would, hey, someone calls up the ER and says, "Gee, I'm coughing up blood. Do I need to come in?" The doctors already got this mindset of, oh, I don't want to get sued, so I got to bring these people in. Plus, you have to have the financial gain. The hospital said, don't want to take any risk, but I would take these calls. So there was a woman who an ENT doctor had operated on the day before. She was coughing up blood, and I was standing right next to the ENT doctor who had done the surgery, and I said, "Hey, Joe, it's Miss So-and-so, we take this call." And it was like Superman and Kryptonite. It's like, oh, I don't do phone. So I took the call, and she was hemoptysizing. She was coughing up blood, but she wasn't lightheaded. She had no signs of being, near syncopal. And I told her something, what to watch for. When I hung up the phone, I turned to the doctor and said, why do you take the call? He says, well, how can you be absolutely certain? I said, because the chances of having a significant problem are insignificant. What would it take to get you to take the call? He said, well, you just gave up $750. Here I am. I'm in the department. We could have brought in we could have gotten a CBC, coags, could have examined her. You could have examined it. I said, let's just put all this aside. What would it take for you to make a call? And this is back in the day when they had phones, touch phones. I slid the phone across the desk to him, and I said, okay, $75, you picking up the call? When I got to $225, he's picking up the call. And that maybe just confirmed for me that, it's not about the malpractice system. It's not about fear of being sued. It's not about the quality of care. It's about the money. He'll take the call for a certain amount of money. And when I established SwiftMD, and we're using emergency medicine physicians for that company, I set the doctors were making $125 an hour plus they make additional money because that's what doctors would. I needed to lure the doctors to work for the company. And that was just, confirmed for me that we have a system that's driven by the wrong golden rule. It's driven by money. We're not giving people the care that they want. or need, but give them the care that we can bill for.
And Swift MD, is that effectively similar to a teledoc platform?
Right. It was just like Teladoc. I think we founded it about 4 or 5 months after Teladoc. I mean, I'm not involved with it, and it subsequently has been sold. But that got
Okay.
me interested in remote patient management. What could be done? How can we equip people with tools at home so that they can control their own healthcare and ideally have to go to physicians as little as possible? This device, so we all have, this cell phone is smarter than almost every doctor in the world. And we should be utilizing this device for care, for people. We actually don't have a doctor shortage. What we have is a misallocation of resources, especially now in the age of these computers. So when I had SwiftMD, I developed protocols for 15 most common urgent care or fast track problems you see in an ER. Ankle sprains, low back pain, urinary tract infection, yeast infection, sore throat. And my goal was to empower people the ability to actually get antibiotics and X-rays for these minor problems, as needed. And I took it to state legislature, healthcare committees in New York, New Jersey, Alabama, New Mexico, and Texas. And I never could get anyone to do the study that needs to be done, which would be, hey, take 1,000 people on Medicaid and give them a system where they can take care of themselves for common problems, and 1,000 people without it, and then see what's the impact on morbidity. There would be mortalities and minor problems. What's the impact on morbidity, and what are the cost savings? And the cost savings would be enormous, and I'm confident there'd be no impact on morbidity. Matter of fact, things might actually improve because doctors tend to overtreat things when we see patients. But I never get anyone to buy it. But it's inevitable healthcare will go in that direction. I don't think it'll happen in the United States. First, it'll happen in one of the more progressive tech environments like the Persian Gulf, probably, or in maybe in the Scandinavian countries or one of the Netherlands. It's too bad.
It's interesting how you take a situation that can be perceived as negative and turning it into an idea that could be generative or productive in some manner. That's what's brilliant about the entrepreneurial mind. And on that topic, you founded and exited several different companies. I mean, is there something that you wish more physicians understood about building something outside of traditional medicine?
Well, the traditional medical system, to my mind, is a problem in and of itself. Most physicians who build them in the context of the current healthcare system because they're seeking reimbursement. But my advice to physicians or entrepreneurs and frankly in general is, first you obviously have to have an idea. Ideally, you start with an idea that is in the area that you know. So, there wasn't that much of my first companies were in emergency medicine, and they were service companies. And they were based upon the idea of, we're going to hire the best doctors and deliver the highest quality of care. Two things necessary to do that. I have to pay more money to recruit them. And to have the highest quality of care means I have to have quality parameters by which I'm monitoring their work. Low uses CAT scans, appropriate approach to pulmonary embolus, diagnosed pulmonary embolus. So I pick problems and have like 3 every quarter that I monitor them for. But the healthcare system doesn't reward that. The healthcare system doesn't give a shit about quality. That's not exaggerating, but it doesn't give enough care. It's not concerned about quality. Why? What are they doing? Well, they're paying the same amount of money for the same unit of care, regardless of the outcome and regardless of the quality of care. And that's why healthcare in our country is so mediocre, because they don't care whether you have a doctor with 1,000 lawsuits or no lawsuits. They don't care whether you have a doctor who, went to John Hopkins, whether a doctor is just off the boat from the Congo. They pay the same amount of money for the same unit of care, and they don't care about the outcome. So my first company was started in that context, and then it's called Pegasus Emergency Group. I did 3 emergency service companies, with Pegasus being the largest, and it was frustrating. And I think physician entrepreneurs need to keep this in mind. If you're delivering a service-focused product, and my focus was on higher quality care, where you get the doctors? Because doctors don't have that mindset. The doctors in healthcare, unfortunately, today are no longer vast majority independent practitioners. They are shift workers. They are well-paid shift workers, and they bitch about it incessantly. And it's part of the whole burnout mentality. Well, if you're a shift worker, you take less pride in your work. If you're a shift worker, you have less control over your workplace and the quality of your work. And so physicians, in my mind, are kind of giving it up. It's almost too late if you want to do something in the context of healthcare. But what is within the system? What do they mean for me in emergency medicine? We'd like to think that 50% of people are above average and 50% of people below average. But in terms of delivering quality care, say something that's mathematically impossible. I'd say 90% of doctors are below average and 10% are above average. It's not necessarily the doctor's fault because I've seen a deterioration in my lifetime. It's the system. It's the way in which they're trained. They're trained especially on emergency medicine. They're trained to be triage doctors today, as opposed to people who comprehensively take care of problems. And if my son were here in the room with me, he'd be bitching about how come you could take foreign bodies out of eyes, and doctors today, emergency doctors, call me, want me to come to the ER to take care of them. How come you could use doctors in your ear could use a slit lamp, but doctors, today emergency medicine doctors can't do slit lamps. It, it's it, it's hard to find good people. So you're as an entrepreneur, you have an idea. Well, you're not going to do it alone. You're going to need people both on your leadership team to challenge your ideas, but also execute your ideas. And you're also going to need providers. And so can you lure those quality providers out of a situation where they are shift workers? And can you get them to deliver higher quality service? That's when they don't have to, where they currently work. No, doctors are not used to having their behavior both as service providers, but also as hospitality providers, if you will. They're not used to having those things be measured, but also being held accountable for them. They're press Ganey scores and things of that nature. One of the things I did early on was reward people for the press Ganey scores. But if the competing company is paying a higher hourly, they don't care about the additional incentive doctors don't care about additional incentive compensation they can make. They'll just stick with the hourly. Why have to work harder or be better, frankly, for just a little bit more money? And so it was really dismaying. And I, when I left emergency medicine and sold Pegasus Emergency Group, I was kind of relieved because it had started out with 3 or 4 contracts with really great doctors running really great departments in New York, New Jersey, and Alabama. But by the time we expanded across multiple states, I could no longer find the quality physicians, and we just become a widget company like Team Health or MCare or any other, Apollo, MD, any other large service companies.
Well, it's interesting to hear your perspective on the healthcare system and how it does not necessarily incentivize providers to provide the highest quality care just because of the nature of the system structure. Something that I need to be more informed on myself as I enter medical school and prepare for the challenges that lie ahead. It's interesting how you mentioned that entrepreneurship, at least as a provider, but generally speaking as well, starts with an idea, starts with developing your team, and in a healthcare context, getting providers that are willing to provide quality care beyond just what's required financially.
Well, that's on the service side, and it takes money. I mean, to start an emergency medicine contract.
Oh, for sure.
We'll say a 30,000 volume ER emergency medicine contract. The startup cost is between $800,000 and $1.2 million. Now that it takes a high risk mindset to take on that debt. Most doctors do not have that mindset. They already have debt if they're young, or if they're middle aged, they've spent years getting out of their debt, and now they're making money, and they don't want to take risks. On the other hand, there's kind of a resentment of those who do take the risks. I mean, having employed hundreds and hundreds of doctors in my career, I'd have doctors tell me, why are you making the money? I'm not making the money. So, well, one, you are making money, but 2, go out and do it on your own. That's the reason. I would actually sometimes tell these doctors, I'll help you if you go find a contract, and I'll provide the seed money. I'll either become your partner, or I will. I'll give you a loan 2 points above prime, whatever. I'll make it easy for you, and you don't have to collateralize your house or your your inheritance. I never found a doctor of the 25 or 30 people who complained to me about it. A lot of these doctors also felt, because doctors have a credential mindset. They like having they have all these acronyms after their names, all their qualifications. I don't really care whether you have an MBA. An MBA is of no limited value in the healthcare system. But the skills that you will need, this is important for entrepreneurs to understand. The skills that a lot of people tell you need to start a business. If you're smart and you're open-minded, and I got to emphasize open-minded. If you're smart and open-minded, you will quickly figure out what you need to do. You hire consultants and you learn from what they do well. You also learn from the mistakes they make, because consultants have all the same problems that doctors do. Most of them are not really good. They know what they know, but they don't think much beyond what it is the knowledge that they acquired early on in their career.
Was Pegasus, was that like a standalone emergency clinic, or was it a separate kind of group?
Separate. So hospitals contract with emergency physicians to provide services in their departments. So it was a standalone. It was a group. We did have some urgent care centers, but it was predominantly focused on emergency medicine practices.
And now your current business project is Firm Tech. Can you describe for us what that is all about, what problem you were trying to solve when you started it, and how your clinical experience may have guided that
Sure.
vision?
Well, front deck is the most fun I've ever had in my life because our mission is better sex and better sexual health for everyone with data. And I feel it was providential. And actually, and this is something I also want to emphasize for entrepreneurs. Planning is everything, and also planning is nothing. And that's not original to me. It's General Eisenhower said that. The point is, you'll have a business plan, but you have to be open to the opportunities that come to you that you don't anticipate. And one can say that they're random. One could also say that they're providential. The question as to whether you're going to, are you going to seize them? You have to have a carpe diem, mindset. It was about 4 years ago that a professor of urology at the University of Utah contacted me about counting the number of nocturnal erections that men have because they're a leading indicator to cardiovascular health. Well, why did you contact me? Well, I live in Montana and I ride horses. And back in 2015, I had a horse wreck. People who ski talk about their powder days. People who ride horses talk about their wrecks. I don't know why, but it's just so much fun to ride. So I broke six vertebrae, and that got me interested in what's been done to rehabilitate spinal cord injuries and sexual function with spinal cord injuries in men and women. I fortunately didn't have one. So I went to the medical literature, and I'm always amused when we call it the medical literature because literature is fiction. And most of the medical literature we now know is fiction. It's not reproducible, tragically so. I mean, we actually have, to digress for a moment, we have a crisis in science. And COVID basically has exposed that crisis. The crisis being how did pharma so capture the FDA and the CDC as to impose on people an untested gene therapy that they called a vaccine, to violate the Emergency Utilization Act, to impose measures that no one believed in before. I mean, social distancing they just made up, masking. There was this. I'm having done research myself on masking back in the 1990s, masking in the ER, and showing this that's of no benefit. Having done, but there's no. My research was minuscule. There's no research saying that masking would be effective. Everybody believed it would be ineffective. This country had survived. I mean, Woodstock was held during a flu epidemic, but life went on, and it was so, from my perspective, predictable that something's wrong. We have our nation's healthcare leaders endorsing things that don't work, and we have all these medical societies, hospitals, and all these doctors going along with it. The conformism to authority just flabbergasted me, and we all now know that it was a disaster. From the vaccines didn't work, probably dangerous. The masking and social distancing damaged the economy, damaged the kids in school, and people not getting healthcare examinations or therapies they should do. But the reason why I think it's just important for people to bear that in mind. So here I am. I get back to myself though, and sex and health. There were 6 papers in the medical literature, peer-reviewed urology papers by leaders, saying that they were able to reproduce arousal and orgasm with neuromodulation. So neuromodulation, we all know about cardiac pacemaking, placing an electrode by the heart. We can control the heart. Imagine being able to pace sexuality. Imagine the impact on the quality of life, not just people who have injuries or diseases of the spinal cord, but upon an aging population, if they could continue to enjoy the physical and mental benefits of sex. And so I tried out 2 rams, male sheep. I placed a veterinary surgeon myself. We placed a electrode by the pudendal nerve and the cavernosal nerve of 2 rams. So we got direction ejaculation, but we also got defecation, urination. So it wasn't bedroom friendly. I then thought, well, I have 2 choices. I could get a business plan and raise money and go down to Brazil or Nigeria, Ghana, someplace like that, test this out on 25 men with erectile dysfunction, or I could test that on myself. So I had a friend who's a urology surgeon plant electrode by my cavernous nerve and my pudendal nerve just above the pubic bone. We tried all different amplitudes and frequencies, and I felt nothing. I actually don't think we know the nerve. I actually don't think we understand basically that one me, but we understand the neurophysiology of sex, and that's shocking, kind of, that we don't understand it because it's so important. It's all throughout our culture, and it's obviously of critical importance and interest. So you're all a so that's so, but that's that. So that's me. I had this. I tried this experiment myself. I'm also involved in developing remote patient technologies because I came out of Swift MD and that got me interested in what could be done for people at home with remote patient management technologies. And now I'm starting to learn about sensors. So I'm not an engineer. I'm not an electrical engineer, not a mechanical engineer, but I'm getting to a point about how you don't, if you build the knowledge on your own. I'm learning, developing a core of knowledge. And I've always been interested in sex. So the first day I went to medical school at Boston University years and years ago, I went to the medical library. They had something called Index Medicus, which still exists. Now it's digital. But Index Medicus had these hard volumes, came out every year. All the research was inside of it. And I pulled out the A volume, looked up aphrodisiacs, and there was like nothing. There's the same type of stuff that you can get online today. Horny goat weed, maca root, L-citrulline, L-arginine. But there wasn't exactly a line of other medical students behind me interested in aphrodisiacs. Different. So I'm interested in sex. I have this. I wrecked my back on a horse. Fine right now, but I injured my back. I get interested in this area, and now I'm working with a doctor at the University of Utah on a catheter to stabilize blood pressure after stroke. And this doctor I'm working with on the last day of ski season in Park City, sitting next to the associate chairman of urology, tells him about this doctor in Montana who's actually put an electrode inside of himself, and that doctor, who's now my chief medical officer, says, I got to work with him. So he's trying to count the number of nocturnal erections that are leading indicator of men's cardiovascular health. Well, we actually don't know very much about sex. We have no data. I mean, it's really shocking. So the problem that we're solving is the incidence of erectile dysfunction by age 50 is 50%. How old are you? 20, 28?
I'm 23.
23. God, looking kind of mature there. By age 30, it's 25%. But it's by my age, I'm 72. It's 70%. And this is a real pandemic. So what's causing it? Why is it so high? They don't know, and they don't know. We now know. We figured it out because we've now documented 84,000 erections. So we have this problem that affects pretty much every man, and the urologists are treating it with very, very limited data. And they've made the classic mistake that doctors make throughout medicine, which is especially academics, set the standards. We project from the sickest people onto the general population. But either it's a curve or they might actually be two different groups completely. So basically, all the doctors are doing is they have these subjective questionnaires, the academics call the IEF, the SHIM score, and the AM score. No need to go into them. And the basis of subjective scores like people A, tell the truth, B, people understand the questions, C, the people also have their own agendas when they answer these things. They're looking for pills. They're looking for something, whether they actually need it or not. So the problem we're solving is why do we have this increasing incidence of erectile dysfunction, and what's causing it, and why is it that what the doctors are doing isn't working? So here's the problem. So ED, which by the way, I hate dysfunction. I'll explain why in a moment. But the doctors have grouped together two different groups of men: men who can't get an erection, with men who lose their erection. Men who can't attain an erection, with men who can't sustain an erection. The academic doctors are seeing in their practices men who can't attain an erection, but that's not the vast majority of men. So they are projecting from that group who have pump failure or arterial insufficiency, not getting blood into the penis, onto the general population. And on that basis, the PD5 medications, Viagra and Cialis, tadalafil, sildenafil, have become their go-tos. But they also, in the office, will get a Doppler because they can bill for it. But they don't have any way of objectively assessing really what's going on for the vast majority of men. And they don't ask the questions because there's no incentive for them to ask the questions. If you go to electronic health record, like the big ones like Epic or Allscripts, there are no questions about sexual health. So here you have this area that's of such vital importance to men your age, men my age, or men in between. That is also a reflection of the cardiovascular health. And it's also a reflection of the medication side effects. It has benefits, and the frequency of sex has benefits in terms of pretty much every body system in the body will benefit from frequent sexual activity. So you have this area that then they're just passing out pills. The electronic health record doesn't tell them to ask any questions. You're a young guy. If I saw you in the ER, you told me I had chest pain in the ER, it's going to make me rule out all sorts of conditions. They're going to make me work a differential diagnosis. And if I come in, there'll be twice as many questions. Did you rule out peptic ulcer disease? You might have dissecting aneurysm. What if he has a pulmonary embolism? You got all these tests. If I went to you and said, penis isn't working the way I want to. You think, here, you just write me a prescription. There are no questions for you to ask. You're not going to ask me whether I struggle to attain erection. You're not going to ask me whether I get erection and lose it. You're not going to ask about the impact of my partners, of alcohol, or taking any medications that could have an impact. Just going to pass out a pill. In a way, it's kind of despicable. And it's not, we like to, people complain to me that this is because doctors are inhibited and people are inhibited about talking about sex. Yeah, but we do rectal exams too. And we ask people about blood in their stool. We ask people all sorts of questions about body functions. That's not it. It's because there's no money in it. And there's no box to check. And in fact, if that changed, the doctors would ask the question. So that's the problem we're solving, is what is really causing erectile dysfunction in men.
Interesting.
Objectively. So this doctor wanted to count the number of nocturnal erections that a man has. How many do you have last night, Curtis? How many do you have? Couldn't tell you. Sleep, right? Exactly. Well, a guy your age should probably have 5. We have not, we have documented 84,000 erections. Probably only about 400 or 500 of those are in men under 30, and they're guys. I think the youngest guy was 26. And we have actually identified 2 problems in young men. One guy had an adrenal tumor, didn't know it because he wasn't producing a testosterone. He was producing extremely low level testosterone. And the other guy was taking steroids as a bodybuilder, and he was able to actually stop the steroids and using our wearable, see the improvement in his function by monitoring nocturnal erections. So the number of nocturnal erections is the leading indicator of man's cardiovascular health. The urologists say that the penis is the canary in the coal mine of cardiovascular disease. And when this doctor said this to me like 4 years ago, I thought, I never heard of that. I'm a doctor. I never heard of that. Have you heard of that? Have you ever heard that the penis is the canary in the coal mine of cardiovascular disease? Did they tell you
Never
that in
heard
the
of it.
cardiology section, the urology section? No, never heard of it. Well, they should. So a leading indicator in medicine is really powerful, because in medicine we treat associations. High blood pressure associated with heart attack, but it's not predictive. I mean, I'm 72 years old, my baseline blood pressure, my systolic went from say 130 to 145. Why should I care? Maybe it's just stress or sleep. I don't know. It's not predictive. It's an association. But if I saw my family doctor internist and he said, "Oh, last year your blood pressure was 128. Now it's 145. Maybe you should take a pill. Maybe take 2 pills, and make all these dietary changes, just on the basis of association." But a
Yeah.
leading indicator means it's predictive. So a man whose nocturnal erections decreased by 50% has a 50% chance of having a heart attack in the next 2 years, assuming that those changes not due to medications like antihypertensive, beta blockers, things of that nature. Well, that's really powerful. But when this doctor said this to me, my thought was, because I'm interested in sex, was why limit ourselves to nocturnals? Let's measure all erections. We have to come up with, let's embed sensors into a cock ring, but one that can be worn both overnight to count the number of nocturnals, how long they last, how hard they are, but can also be worn during sex to measure how long a man lasts and how hard they are. And with this, men and their doctors can now measure the impact of diabetes, hypertension, atherosclerosis, medications, prostate disease, alcohol, recreational drugs, relationships upon a man's sexual performance, but also can reflect all these other conditions, physiological disorders. And we're now giving men the vital signs of their most vital organ, because what do men think about? That's a rhetorical question. Maybe not you, Curtis, but what do most men think about a lot? And that's sex. And so it's men go 3-4 days without having sex, like they feel like they're, especially if they lose their erection 3 or 4 times. Well, that's a crisis. And I could tell you, if I've been in emergency medicine, short of a heart attack or a stroke, there are few emergencies that concern a man as much as a consistently limp penis.
Just looked up here. A 2011 study found that men on average think about sex at least 19 times a day. And then another one says, if we believe the stats, thinking about sex every 7 seconds adds up to about 514 times an hour. So, I mean, yeah, clearly a lot. Clearly a lot.
Yeah, well, clearly,
And
environment plays it plays a factor in that. But yeah, and by the way, and an orgasm a day probably keeps a doctor away. People don't get this. We know that men and women who have an orgasm every day can reduce their cortisol levels at a minimum of 25% and a maximum around 50%. Well, think about the cortisol is stress hormone. Maybe we should be telling people, before you try this pill, why don't you try having sex, go masturbate or have sex? We don't do that as doctors. Maybe we should. was a big study out of the UK, a really big study. Off the top of my head, it's like with several thousand men. It's on a science section on the website. But men over the age of 70 who had sex twice a month, as opposed to less than twice, sex twice a week, excuse me, post sex less than twice a month, they decreased their risk of cardiac death by 50% over the next decade. Well, that's a
Interesting.
big number. But
Yeah.
what doctor? I've never had a doctor tell me, "Hey, Elliot, oh, it's 70. You really should, be certain you have sex at least twice, twice a week." And then just think about the social impact of sex. So we know the couples that have sex 3 times a week, married couples that have sex 3 times a week, versus married couples that have sex less than twice a month, have half the divorce rate. And we know the impact of divorce upon the health of the people who go through the divorce, but also upon their children. Alcohol, drugs, completing school, going to college. All these things are improved when couples stay together. So we should be, as doctors, actually be recommending sex to people, and we don't. And I've actually spoken to now 3 heads of departments of health in different states in the United States, and said, "Why don't you guys come out with this?" I mean, he has a measure that's it doesn't involve, not take any money. Just go out and tell people to have more sex because of just the social benefits. You owe it to society, if not to yourself, to have sex. I've not succeeded yet persuading any chief at head of the Department of Health to say that, but it'd be great.
So, and you talk about, quote, erectile fitness as a vital sign. Why is this something that every physician should care about? And should it change the way we think about men's health?
Well, I invented the phrase erectile fitness because we live in a fitness-oriented society, and also we want to talk about sex, sexual health. It's not something that's positive, and we want to end the embarrassment and shaming that goes on with sex, especially for men. Early on in my medical career, in the late 70s and 80s, women were still being described as frigid, cold, anorgasmic, hysteric if they had sexual problems. And the feminists came along, appropriately said, "We're not going to talk about women that way anymore. It's wrong. We want to try to figure out what the problem is, and we try to address the problem." So it's called FSD, female sexual dysphoria, and you never hear that. We talk about ED a lot. We don't talk about FSD. Hey, women have dysphoria. We don't do that. From my perspective, the man who can't attain erection struggles to attain erection. That's dysfunction. And I think it's appropriate for us to try to alarm people by saying that's a real problem. You need to see a cardiologist and neurologist to get that assessed. But for the men who get an erection and lose it, that's a problem. It's one that we can address. Why even talk about it as dysfunction? It's just yeah. So it's a lot. So I like people to start the as I'm losing my fitness. I'm 72 years old. I'm in fairly good condition, but I can't do stuff I could do when I was your age. It's a fitness issue, and I can probably make myself fitter in certain ways that maybe I could keep up with you in a run or whatever. But it's a fitness issue for men. One of my goals with this company is to use platforms like this, or larger platforms, to talk about men's sexual health in terms of maintaining their fitness. So we're all men, even a man as young as you. We're all on the road from erectile fitness to erectile dysfunction. Where are we on that road? This is the problem in general for a man your age. Where are we on that road? And ideally, of course, if we have a problem, if our fitness is deteriorating, we want to address it, just the way we go to the gym, or the way we stop smoking, or we don't drink, or we drink less because we developed a problem. We all would like to know where we are. We don't have a dashboard, and our device, the tech ring, has a dashboard. It'll tell you where you are. It'll tell you, am I above average? Am I below average? It'll send you a notification. Hey, Elliot, you started on a new medic. I think the computer can actually interpret this. There's been a change. Your erections are 30% less firm, or lasting 30% less as long this last month as they did the month before. Are you taking new medication? There has been some change in your life while you're having social issues, et cetera, et cetera. Or it could be an alert. Like if you're, hey, Elliot, you were averaging 3.5 nocturnal erections per night, and now you're at 1. It's highly likely that you have a significant cardiovascular problem. You need to see a doctor. So with data, men can start getting control of their sexual and as well the cardiovascular health, because without it, we're blind. So where are we on this road? And we give men a dashboard, and that's profoundly valuable. Plus, we've also discovered that the doctors are mistaken about the primary cause of erectile dysfunction, because we have data now, and they missed it. What's really interesting sometimes in healthcare, I'm certainly experienced this, Curtis, in the course of your career, is sometimes you look you look back and you think, wow, how did we miss that? Why are we doing that? And it's so obvious that we should be doing something, something else. And that's one thing's been most fun over the last year, because when we launched the company like 2.5 years ago at the Consumer Electronics Show, our database had like 800 erections in it, of which maybe 30% were probably mine, and another 25% were probably Adam, who was a young guy your age, our data analyst. Now we have 84,000 erections, and that is what that data, and as that data set grows, is going to change urology and sexology. It already is having an impact on quite a few people who are aware of it, and as we publish the research and publicize what we're doing.
Do you see this device as becoming something as popular as a glucose monitoring system or a
Definitely.
sleep wearable?
Yeah. Well, I think 3 to 5 years from now, it'll be the standard of care.
Mm.
Not for someone your age, Curtis, but for a man who's 45, 50 years old, or a man who has significant diabetes or hypertension, they're going to want to know your erectile fitness score. Your doctor is going to want the man, is going to want to know your erectile fitness score, just the way you want to know when you have an annual physical. You want to, if I went to a doctor right now for physical and he didn't do an electrocardiogram, check my blood pressure, order screening panel, lipoproteins, inflammatory markers, et cetera, I would think, what is this, 1900? In the future, people are going to say the same thing about you don't care about you don't care about my sexual health, and we don't care right now, and it's wrong, and we should care, because someone's sexual health is an indicator of the cardiovascular health, as well as their psychosocial health as well too. Yeah, so I think this will become the standard of care.
Okay. Very interesting to hear about your business developments, what inspired you to do so, the fact that we're lacking data on sexual health. And of course, you mentioned there is a level of apprehension in discussing this with patients for various reasons, having this sort of discussion with patients, and that's going to be one of the hurdles to overcome. And I guess otherwise it would just be a matter of continuing to develop the information and justifying the research behind it and why it may be beneficial to further investigate.
Well, two things I wanted to emphasize. Point out. One, well, what's next? Women. There's no device to measure the health of the clitoris, and we have invented it. And we've tested it on 28 women, and we will be bringing that out for research, hopefully by the end of this year, if not the end of this year, the first quarter next year. And that will transform gynecology and sexology for women. Because women have even more problems than men do. They might want to blame their problems on us. But younger premenopausal women take birth control, take hormones, and they take antidepressants more than men do. And those things have a significant negative impact upon their sexual health. And to which women in general take more medications than men. Our thesis is that women have nocturnal clitoral erections. We know they do from Master Johnson, but we don't know how many. We don't know how long they last. We don't know what the norms are. It's just, it's 3 years from now. If you ever have me back on a podcast, I'll just say, hey, Curtis, here's the data on 50,000 clitoral overnight clitoral nocturnal erections, or 100,000, or some number. And here's what we learned from it. So what we learned on the male side is that the major problem for men is venous leak. And I mean venous leak like some of the people born with congenital venous leak, with letting blood out of the penis. But the venous leak of aging is what I call it, which is that as we get older, the smooth muscle around our venules weakens, and the end result is that blood leaves our penis faster at my age than it did at your age. And if you pay attention, Curtis, if you're like most men, you are going to witness the deterioration of your sexual health over the next 10 years. Because as much as women like to complain that men get all the attention, and we do, we get more attention, certainly when it comes to research in cardiology and other areas of medicine. When it comes to sex, we get a lot less attention. Every man experiences between your age and the age 35 or 40 two significant areas of deterioration. One is that they lose their erections faster, and their refractory period deteriorates. And we don't know why that happens. There is zero data about it. No one has researched it. And that's so in this sexist obsessed society that we have, it's really incredible that these two things that start affecting men at a younger age than women have problems have never had their research whatsoever.
See, and Dr. Justin, something interesting about your history is that you studied Slavic literature at Harvard. I want to ask you, how has that influenced your way of thinking as a physician, as an entrepreneur, just as an individual?
Well, in the past, people wanted doctors to be humanists. And they wanted, the expectation wasn't just that a doctor would be a medical scientist, but the expectation that a doctor would also be well educated and cultured. And I think that reading fiction, studying slavic language literature had two impacts on me. One, reading fiction aside from the entertainment value, there's also an education about human nature, especially reading Tolstoy or Chekhov, who are really accessible and really and brilliant. But studying Slavic language literature also meant studying a lot of Russian history, and that made me fear communism, fear authoritarianism. And at a time when many of my peers were in medicine were looking for social solutions to public health policies, it made me skeptical that those solutions would work. And we saw the disaster of medical authoritarianism during COVID, as I ranted earlier on in this podcast.
You've emphasized the danger of let me rephrase that. You've emphasized the danger of dogma in some of your, how do I want to phrase this question to you? And in reading about you, I've noticed that you've emphasized some of the danger of dogma. How do you think doctors can cultivate some intellectual humility
Yeah.
without losing confidence in themselves?
Well, that's a great question. I think the key, at least in emergency medicine, was the differential diagnosis. We all have a tendency to have an idea of what the problem is and to go with it, and to not think about differential diagnosis. It's important that we, whether we're in medicine or in business or in life in general, that we consider ideas that are antithetical to ours. It goes back to a German philosopher named Hegel. Actually, goes back. It's an old philosophical concept, which is that for every thesis, there's an antithesis, and you can't. And then you have to challenge the thesis with antithesis, and then you get the synthesis. And then you need to even challenge that too much. So there's always this A/B testing, if you will, as they say today, of ideas that needs to go on. And I don't see enough of that in medicine. I see doctors overall as conformists. They go because that's how we succeed in medicine to some degree. We get in because we study real hard, and we get good grades, and we get professors to like us, and we get recommendations. That the system is training us to conform as opposed to rebel or be independent. Not necessarily rebel, but be independent. I think when doctors were independent practitioners, they were much more independent thinkers. And now the system is selecting against that. And I don't think it's good for medicine. I think that part of the disaster, the COVID authoritarianism, occurred because of that. People just went along with what authority was saying.
And from what you've studied, why do you think it's so important to think clearly, think freely, and live accordingly?
Well, I think it's important to live with honor and with wisdom and even with courage, rather than with embarrassment and shame. Might be just be yourself and with submission to authority. But it's really hard for people. It's. I mean, even when you're trying to do good. I had my medical license threatened 3 times over things where. I mean, I'm not talking about prescribing 1,000 Percocets to someone. I mean over medical advances. The first time was. I was on a governor's commission in New Jersey to improve healthcare. And at that time, I had an emergency medicine contract in Trenton, New Jersey, and I noticed that the nurses joked about it. It was Baby Mama Monday. So the first Monday of every month when the welfare checks went out, and there'll be more violence around that time because multiple fathers might show up to try to collect money from the same woman. And my suggestion was a practical one. Why don't we randomize the welfare payments? So these parasites don't know when the money's coming in. And I got nowhere with that idea. And I wrote an editorial about it and had the Department of Health contacted the hospital I was working for and said, we don't want to do this. And then I didn't let go of it, and it ended up being told. I thrown off the committee for, among other things. And I had another time where I was an early advocate of lateral mask airways by EMTs, and the paramedics didn't want to give up that skill. They want to these providers with lesser training, and I did a research project showing that EMTs could be trained to insert LMAs just as well as paramedics. And I was accused of falsifying the research data, and of getting money from the company that provided the devices, both of which simply weren't true. And it escalated to the point where I with the head Department of Health in New Jersey, the cardiologist I knew, told me that if I don't cease the research, they will pull my license. And I said, I'm not going to stop the research and delivering this quality of care in the 2 counties for which I was responsible in New Jersey, because you accused me of something without even looking at the records. Anyway, I think it's important for people to live with courage. I think we'd have a better society if people live with courage rather than going along to get along.
Interesting. Now, on that note, what advice would you have for today's medical students just now entering the field, some new residents, or even a new attending physician to navigate the challenges of the day, to live with courage, to think freely.
Well, you're entering the healthcare system at a time of really profound challenges, which is how you're going to maintain humanity in a system that's moving towards artificial intelligence.
Mm.
Uh, what systems, in what way can you as a human being be better than a machine? That's going to require living with humility, recognizing what our strength is, what we can deliver as opposed to machines. And that's going to mean more empathy, more old school style medicine. I mean, you read accounts of 19th century physicians, and they're like staying up all night with people who are dying or ill, and and they couldn't do anything other than be there and deliver the reassurance from their presence. I think what distinguishes us from machines with
Our
our humanity.
consciousness.
Yeah, is our
Yeah.
humanity and our empathy. And I think it's going to be a challenge to a system that doesn't reward it. There's no money in it. Matter of fact, it's probably going to produce friction. I mean, when I left my largest emergency medicine practice in New Jersey, where I'm still practicing medicine, at the farewell dinner, the consistent joke was, "Oh, we're all going to make more money now because you made $55 less a visit than the group average." The system rewards the quantity of care, not the quality of care, and that's a challenge for doctors because they're how are you going to how are you going to actually, I think, increase your empathy and distinguish yourself from machines in the future as a quality provider when the system doesn't reward it? But the rewards, from my perspective, the rewards really are in your heart.
At the very least, that's for sure. So ultimately, determining how you're going to navigate the advancement of AI, continue to provide quality care, and maintain a sense of humanism. So, Dr. Justin, I have a couple more questions for you
Sure,
as
go
we
ahead.
wrap things up here. What kind of legacy do you hope to leave with the work you've done? And, well, yeah, let me rephrase it. With the work you've done, what kind of legacy do you hope to leave?
Well, that's why I feel blessed by Providence to have this particular project. Without this project, I would have been continuing to consult in technology in the areas of diabetes, cardiology, and emergency medicine. But this project is going to change urology, sexology, and gynecology. I mean, it might not be our devices used in the future, but to bring data to fields where there currently is no data, to go from providing people with objective, actionable, and most importantly, personal data, that's profoundly valuable, and that's a legacy. And I'm lucky this came to me at my time of life. And I hope people make love more. I hope as a consequence of this, people have better marriages, better relationships, make love more, are happier. I think it'll be a better place. I hope.
Absolutely. Absolutely. And as we wrap things up here, sir, do you have any pieces of advice for our listeners in line with the mission of this show, which is to help optimize the journey of lifelong learning and self-improvement in medicine and beyond?
Don't become a shift working drudge. You have a mind and a heart. Don't let work stress become a source of unhappiness. Just continue to learn and continue to. And we have this gift being given to us as doctors of helping people, as opposed to whining about people.
Well said, sir. Folks, we've been talking with Dr. Elliot Justin. Dr. Justin, thank you for sharing your interesting insights and experience with us today.
Thank you for the opportunity. It's a pleasure.